and it's a real pleasure to be here with all of you today. And good morning, still morning, Glasgow. I'm doing two of my favorite things. One is talking, that I like talking a lot. So please, John, tell me when I need to sort of finish. And secondly, talk about the bowel as well, because it's my specialty and I am really engaged with it. And after the session that we had before the break, that we finished with a high of the sorrows of bowel preparation, I want to take these 20 minutes to just take it as a motivation talk of why are we doing the colonoscopies. And I would like to take you through the journey of what happens during a colonoscopy, what happens in the colonoscopist's brain, and what can we offer in order to hopefully keep reducing mortality related to colorectal cancer in Lynch syndrome patients.
Oh, the one on the podium, the green button on the left.
Thank you, Ben. So Ben and I will go a very long way. So, obviously, you know that Lynch syndrome can affect 1 in 300 and 1 in 400 people. In the UK, there are roughly 300,000 patients with Lynch syndrome diagnosed, but probably more. And we know that not everybody with Lynch syndrome has been diagnosed. And more or less annually, we diagnose around 1,200, 1,300 colorectal cancers annually. So a sporadic colorectal cancer, or because of other mutations, more or less the sequence. And I'm going to take you through some pictures so that if the ones of you that maybe sleep a little bit during your colonoscopies, so today it's the day of checking what we are seeing. So you can see on the left-hand side, we have a normal bowel, then we have a precancerous polyp, and then after many years, probably 10 to 15 years in patients with no identified mutation, it develops into bowel cancer. And from a quite nice meta-analysis, and what does it mean, a meta-analysis, when we see it published in research articles? It means a couple of clever people that have gathered all the evidence published in the literature, sometimes with conflicting messages. Some research say yes, some research say maybe, some research say no. They put it all together and try to come up with a sort of a conclusion of when we think the trend of the new developments are heading towards. And we know that in patients with Lynch syndrome, actually the cancer between a normal bowel and a cancer, things can be a little bit more different. Some of these patients may develop a polyp, a precancerous polyp, and that precancerous polyp will develop into cancer. Some others, the alteration happens a little bit deeper into the layers of the bowel, and then the cancer appears without a proper big lollipop lump that has been identified. So it's a slightly more complicated, and that's why spotting precancerous lesions through colonoscopies in patients with Lynch syndrome is slightly more difficult. They tend to be more in the right-hand side. They are probably a bit flatter, less apparent to the bare eyes, and that's why we need to pay a bit of an interest. So, one thing that is clear, though, is that if you look at this meta-analysis, so all this data together and a bit of let's see what we see. Patients that they know they have Lynch syndrome and they get diagnosed of colorectal cancer, actually their survival rate seems to be much, much better. And as you can see here, 10-year survival rate, 88%, whereas the patients that get diagnosed through the normal route with no Lynch alteration, we are not doing very well. Actually, the survival rate at 10 years is probably around under 60%, mainly because most of the cancers are caught in a very late stage where curative treatment might not be possible. And as we will hear and we have heard before, sometimes novel treatments like immunotherapy don't work so well for patients with no Lynch syndrome. One thing we know from this meta-analysis is that actually the colonoscopy surveillance seems to lead to a significant reduction of colorectal cancer mortality. And hopefully that's going to set the trend of please engage with the surveillance. I am fully aware, because I look after patients with Lynch syndrome in my clinic, that some of you, especially if you've been diagnosed through cascade testing because of another first-degree relative, and you need your surveillance when you are 25 or 35, in your lifetime, probably you are gonna need an average of 20, 25 colonoscopies, which is a fair amount. And I know how challenging it is to take the bowel preparation. I have tasted myself on my own experience, and it's not a pleasant day before the colonoscopy to have, but actually engaging to the preparation that is required before and engaging to have the surveillance colonoscopies, it can reduce significantly the chance of dying from bowel cancer if that occurs in your lifetime. Why the bowel preparation is so important, and we heard that, well, because we need to see. You need to think that when we are performing a colonoscopy, it's like having a couple of Google eyes and we are in the deep blue sea looking for algae and fish. If the water is very turbid, then we may miss the fish and the algae. And as I said before, in Lynch syndrome patients, the polyps tend to be quite flat, so they are not there waving at you. You need to have a very good look. And as you can see, there is here the top corner picture, that is a bowel. And if we look at the picture like if it was a clock, at 4 o'clock, I think everybody can appreciate there is a residue of fluid. It's not solid feces. When you have taken the bowel preparation, you can see liquid, but liquid is not good enough. You need to see clear liquid, because otherwise it's like swimming in a swamp. I may miss the fish in there because I can't see it. So unfortunately, there is not another way around but to stick to the bowel preparation, because if there is a flat significant polyp beneath this paddle and I cannot clean the paddle very well, I'm going to miss it and tell you the colonoscopy was fine, and actually it wasn't fine. And obviously we also have to take our time on withdrawing our scopes, because we know the longer we take in coming back and looking at every corner, the higher chances are that we are going to pick up lesions. So sometimes you might be there and thinking, why is taking so long, and why they are moving me in one way and another, and now they are asking me to turn on the back and go back to the left and back again. Is basically because we want to make sure that the lining of the bowel exposed in front of our eyes is the maximum as possible. All right? Well, it's been said already in previous talks that depending on the alteration, you will start on your screening on earlier, 25 or 35, and every 2 years. It's been considered, again, by the evidence that we have gathered so far, that is the reasonable interval that you should have a screening. Having said that, the reasonable interval that you will have a screening, providing that you don't have any new symptoms in the meantime, because the colonoscopy is the best test that you can have to screen for bowel cancer, but sometimes we may miss bowel cancers. So don't think if there is something new. I had my colonoscopy 11 months ago. I'm not going to say anything to anyone and wait for my next turn when it's the 24 months. Raise it with the GP. Always, as anything else, the first thing you say is, I have Lynch syndrome, and that already puts the GP on an alert, and then you can describe symptoms and you can be fast-tracked if the symptoms are significant. So the 2 years interval is providing that everything remains the same. What is the role of a colonoscopist when we do the colonoscopy? So I have the patient with Lynch syndrome, and what do I need to do in order to make the whole experience a good experience. So I have to make sure that the patient is comfortable, that you guys are comfortable, because you are going to come to me at least 15, 20, 25 times. Well, maybe I will retire and you will see somebody else in the meantime. But we are going to be part of family, of seeing each other quite often. So it has to be comfortable so that you don't feel stressed and anxious about coming back next time you get the invitation. We need to see the lesions very well. So we have to be skilled on detecting the lesions. When we see lesions and growths, we have to be able to characterize them to see if they are alarming growths that we should take and pay more attention on. When we see these lesions, we should have the ability to predict what is the likelihood of any cancer cells on this lesion as well. And then, once you do that, you need to think, is it a lesion that probably is not going to have any cancer, so I can remove it now? Is it worrying? I take biopsies and send to the surgeon. So all this is what is happening in our brain when we are doing the colonoscopies. So let's talk about the comfortable intubation. For instance, more and more in our endoscopy units, we adopt a way of intubating the bowel that is called by water immersion. Most of you, when you had your colonoscopies, you are very ballooned with a lot of gas and feel very bloated, and that makes it very uncomfortable. Now, we are adopting a new way of colonoscoping that is, rather than expanding the bowel with gas, we do it with water. And by doing that, the bowel doesn't get so much stress and stretch, and patients do much better. You have to think, the analogy would be, if you have a balloon and you just blow the balloon with air, that the wall becomes quite tough, or you are doing balloon bombs with water that actually is more squidgy and less hard. And here is a small video for you to see an example of how do we do the water immersion colonoscopy. So as you can see, I'm just going through the little folds of the bowel, and rather than using the gas, I have a foot pedal that just injects water and makes my way into the bowel, and that makes it much more comfortable. So you loop much less. The little rectangle that is the blue rectangle in there that you can see a little worm, this little gray worm is the shape of the colonoscope inside that patient body. And as you can see by water immersion, you can predict very well where the turn is going to be, use the water and turn very slowly and make it comfortable. And by using this technique, 98% of patients, including patients that had hysterectomies, find it quite comfortable. Now, while the video is running, someone asked me during coffee, are the colonoscopies specialized with Lynch syndrome better than the non-specialized with Lynch syndrome? The British Gastroenterology Society has done an immense amount of work in order to achieve minimum quality standards among colonoscopists. And we get constantly measured in our single cases of how good we are. And we get sent our performance every 3 months. And if we are not very good, we have someone in our department that is gonna tap in our shoulder and try to identify the reason why we don't reach these standards. So the way colonoscopies are done across the board nowadays is very different to how it was many years ago. And actually, we get these reports, and you can see, for instance, that's my disclosure. So we have a national endoscopy database that every single evening with all the colonoscopies across England have finished. I don't think is ready yet for Scotland, but when all the endoscopy units are shut, there is a software that sends all the data to this national database, and then it produces where you are in terms of your quality performer indicators. For instance, did you reach the cecum? Did the patient have pain? Did you have to use a lot of sedation because of the pain? Did you find polyps? Did you remove the polyps? Did you retrieve them and send them to the lab? And there are some minimum percentages that you need to tick in order to ensure that you maintain your quality. All right? So hopefully that gives some reassurance, but there is more. And I'll go back to this point in a minute. Here you have two examples. I don't know if you can see it very well. These are two polyps, right? On sort of bare eyes, you can see more or less are the same size of polyps. They are both located in the same area of the bowel, so in the rectum, very close to your back passage, and you are the colonoscopist and you see them both. So what happens when you see them? So you first need to diagnose it and say, I think it's a polyp. Yes, I think everybody here can say that. And then when you look at the two polyps, you need to predict the risk of these polyps having cancer, even before having taken the biopsy. For instance, and I know we are not all trained, how many people think that the picture on the left-hand side is a small cancer? Hands up. Don't be brave, because this is what we do. Okay, so 1/3. How many people think that the picture on the right-hand side is a cancer? So this one here. Okay, equal numbers. How many people think that none of them are cancer? How many people think that both of them are cancer? Okay, equal numbers. So as you can see, it's a bit difficult. And as colonoscopists, we get trained on what is called optical diagnosis, that is recognizing the pattern of all these lines in here in order to predict if it's cancerous or not cancerous. Hence, the bowel preparation has to be pristine, because I should be able to see these little lines in here and these little lines in there, and then come with my prediction, because my prediction will affect what do I do with this lesion at that point on time and in the future. And I can tell you, the one on the left-hand side is a cancer, and the one on the right-hand side is not a cancer. And it's all based on the lines that you learn how to interpret. And once you reach this conclusion, then you think, what do I do? Do I remove it now? Do I remove it later? Do I just take biopsy and send it to the surgeon? So this is what's going on when you do a colonoscopy. We are not just there talking about lunch or our holidays. Our brain keeps functioning in order to do that.
They sometimes talk about lunch too.
No, we are able to multitask, talk about lunch while thinking. But when we are diverting quite a lot from the conversation is when you have the amazing nurse and the endoscopy nurses that they say, you missed a polyp. Oh, thank you, yes. So it's a teamwork in the unit. So as I said, optical diagnosis is what we do by looking at the bowel, using some filters in order to see the speed patterns in the polyps. And while I'm doing that, I'll run another video. So you can see we are withdrawing here, and everybody can see at 8 o'clock in the screen, there is something not quite right. So we can see a lump that is very red with some lines in there. Now I'm using a filter to analyze a bit better these sort of lines and pit patterns that look like a mini brain. And then I can see that this is actually what we call a pedunculated polyp. So it has a stalk and the polyp is on top. And when I look at the surface pattern, it looks quite benign to me. Therefore, I can tackle the polypectomy right now, because probably I'm not going to compromise any further treatment because it looks benign. So, great news when I heard that bowel cancer screening in 2023, Fiona already touched a little bit upon it, embraced the surveillance of patients with Lynch syndrome. Just to give you a bit of a storyline, why it didn't happen sooner. Right, I have to say that even not being born and bred here in the UK, I feel incredibly proud of the bowel cancer screening in the United Kingdom. I think we are ahead of anywhere else in the world in terms of screening because we have managed to put it to a wide population. However, there is always the balance of not breaking the NHS money funding and trying to capture as many patients as possible. And that's been a very long journey. So the bowel cancer screening started in 2006. We started quite shy. All the doctors that are screeners have to go through an accreditation exam. And when you haven't done an exam since medical school, feels quite daunting, especially because it's a practical exam where you have two guys looking at you, scoping and tell you you are good enough or not. Mm-hmm. And the pass is not 100%. I can tell you many colleagues have to go 2 or 3 times through the exam in order to get the accreditation. So a lot of workforce had to be trained and reach the standards to get the accreditation. We started in 2006 with a very shy bracket that patients from 60 to 69, they would get the invitation. Then we started to extend the years. Then we changed from one kit that was very fiddly, that you had to put poo in through windows, and the 3 windows, and people didn't like, to the fit test that is much easier. So it's just one small stick of poo in a pot and everything it's less fiddly. And then we had to think how we could rationalize it, because we were surveying a lot of patients for very small polyps that they kept coming over and over again every 3 years, and just filling our rooms and getting our capacity of new patients a bit smaller. So we had new guidelines of which patients should come back after polyps or not. And then optical diagnosis of very small polyps was introduced, because believe it or not, in the UK, only 3% of pathology labs, so the doctors that look at polyps on the microscope, are fully staffed. So we were sending all these 2-millimeter polyps for them to produce reports, and actually the big staff was not getting reported on time because they were too busy on that. So the optical diagnosis of small polyps meant that we gastroenterologists got an accreditation to establish if very small polyps have cancer, yay or nay, and the ones that we thought they don't have cancer, we don't need to send them to the lab, so the pathologists can go on with more significant findings in terms of getting their day. When all that happened, we realized the Lynch syndrome patients are a higher risk population. The best colonoscopists, they are the bowel cancer screening colonoscopists that have gone through this accreditation. Lynch syndrome patients should come into bowel cancer screening. And especially that was highlighted during the pandemic, because as many of you probably experienced, the endoscopy units have to be shut. We were really struggling with patients with symptoms and so forth. And actually the care of Lynch syndrome patients across the nation was a bit patchy and heterogeneous. So 2023, the bowel cancer screening embraced the Lynch syndrome surveillance. So many of you maybe had your colonoscopies done in one hospital by some team, and then you got the invitation to your local bowel cancer screening program. That's why that happened. And actually, then the surveillance routine of 2 yearly, 25 or 35, depending on the alteration, took place. So that, and I think, I don't know, maybe during question time you can tell me about your experience, but I think that's been a fantastic milestone for the screening of the patients across the nation. Now, let's talk a little bit about treatment. What do we do when we see lesions? So here you can see a nice polyp. is a lollipop type of polyp. And usually what we do is that we inject the little stalk in here with a little bit of adrenaline. And adrenaline is a substance that sort of causes the blood vessels to shrink, so that when we put a snare, then the likelihood of bleeding is much less. The inner layer of the bowel has no nerve endings, so it means that we can put needles, we can put snares, we can cut flesh, and patients don't feel any pain at all. So that's why it's very forgiving. And once that's on, then we put a lasso. We try to embrace the lasso around the polyp. As you can see, there is like a little baby sister in there that we don't want to leave behind. And then once we feel that the lasso has passed through the whole stalk, we sort of close the snare, and we use electric current to cauterize the blood vessels, and basically we cut it. And it's a pretty beautiful thing. This is where I live all day long, you see, so I feel like home looking at that. And now in a minute you will see that we are just navigating with the snare, and then the polyp gets caught. Because you see, sometimes there is a bit of the wire that is still catching half of the polyp, and we just want to remove the polyp in one piece, because leaving half of the polyp behind would put you at risk of the polyp growing again and transforming into sort of a bowel cancer.
So hands up if you think it's beautiful.
See?
How long have you been doing this, Rosie?
When the bowel prep is nice, it's a nice thing. It's a nice thing, yeah. I just want you to see the polyp cut, that's why. Now you can see, because it's not fast forward, that we take our time in order for that to happen. And hopefully, come on, Dr. Vega, cut the polyp. There is another patient waiting.
You need drinking Coke, been drinking Coke this morning.
Yeah, exactly.
Did the patient give his permission?
Say it again?
Did the patient give their permission for you to show?
Absolutely. Otherwise, I wouldn't show it. Absolutely. No, and actually at UCH we are very strict on showing videos without permission. So the polyp is out, all right? And you can see it here. It's been lovely removed from the stalk. In there.
Rosa,
Yes.
Rosa, it's Kathy Walton Glass